This lecture is kind of on the long side, so we're going to keep the warm-up on the short side. The question says, what are the equations for sensitivity, specificity, positive predictive value, and negative predictive value? So sensitivity is the true positives over true positives plus false negatives. Specificity is the true negatives over true negatives plus false positives. Positive predictive value is true positives over true positives plus the false positives. And the negative predictive value is true negatives over false negatives plus the true negatives. Now make sure you know all those equations really, really well. Now let's go ahead and get started with the lecture.
In this video, we're going to discuss the healthcare system in the United States. This is something that is definitely important for you to know, both professionally and for your Step 1 or Level 1 exam. You will have a question about the healthcare system on your exam. Maybe you'll have one question, maybe 5 questions. But it's something that you really do need to understand, and it gets largely ignored in other review courses and review books. So we've given you much of this information in your study guide. We have this quote in your study guide: "Medicine is a science, healthcare is a business, healing is an art." I heard this as a medical student, and I mention it here to remind you that our healthcare system represents a complex intersection of medical science, economics, corporate legal entities, and the psychosocial and spiritual aspects of healing. In some ways, each of these components stands on its own, but in other ways they are very much dependent on each other. Let's start with this first question in your study guide. What was the practice of medicine like before insurance? Well, physicians and hospitals could charge whatever they felt was fair to patients. Patients trusted physicians and hospitals to charge them a fair rate for their services. Patients sometimes incurred excessive, unforeseen medical expenses. Patients often were unable to financially compensate healthcare providers for their services rendered, and instead might offer something like chickens or handmade crafts. Physicians would write off debts that patients were unable to pay. So without insurance, there was a certain degree of imbalance in the healthcare system. One of the goals of medical insurance is to establish more foresight and fairness in the system, where there's prepayment for anticipated future ill health. In this way, the system becomes more balanced over a long period of time, rather than having a lot of short-term disharmony. So in order to move on, there are a few healthcare terms you need to know. Look at the next question. Health insurance has premiums. What's a premium? It's the amount the insured person has to pay the insurance company. Usually it's a monthly premium. Maybe it's $200 a month, maybe it's $500 a month. A copay is the amount the insured person pays at the time of service. So not only do you have to pay a premium every month, you also have to pay a copay every time you go to the clinic or the ER or for an outpatient surgical procedure or for an inpatient stay or whatever the visit may be. And a deductible is the amount an insured person must pay out of pocket before the health insurance begins to pay for the remaining healthcare expenses. So if you have a high premium plan where you're paying maybe $1,000 a month, your deductible is probably very low and it's not going to take much money to reach that deductible. But if you have a low premium plan, you're only paying, say, $100 a month or $50 a month, you're probably going to have a very high deductible where the first maybe $5,000 of medical care is not covered by insurance and must come out of pocket. Next, let's talk about this third-party payer system or private pay health insurance. Take a look in your study guide. In the third-party insurance system, the financial duty of the patient is to pay the monthly premiums, copays, and deductibles that we just discussed. There's a risk here, and the risk is paying more in insurance than what is actually received in medical care. And this is particularly common in young patients who pay into the system but don't need much health care. So from a certain perspective, it's a waste of money for a young patient to buy insurance. And we'll talk about why that's an issue in a minute. The reward is, number one, that there's a financial benefit if the cost of medical care exceeds what is paid to the insurance company. And number two, there's peace of mind in knowing that you have insurance to pay for any catastrophes. And this peace of mind is really important because if you're worried about what would happen if you got ill, you're not going to be as productive as you could be. Moving on. Now, from the perspective of the insurance companies, they have a financial duty to pay the healthcare expenses beyond whatever the patient is required to pay. The risk they are assuming is that they might have to pay out more than what they are collecting from the patient. And they try to spread that risk over their entire subscriber population so that it's more fair. The reward or profit to the insurance company comes if the patient pays more into the insurance than the company has to pay out for the healthcare expenses. Again, over a long period of time. The next question says, what problems came about when health insurance was introduced? In short, everyone tries to get the biggest slice of the financial pie in the hands of the insurance companies. Before, you just had physicians and patients. Now you have third-party payers, and everyone's trying to get the most out of the system. Health insurance companies leverage their volume of subscribers to drive down their reimbursement to medical care providers. Providers still provide the care because they agreed to do so. Healthcare providers and hospitals counter by increasing the cost of medical care. Insurers pay because they agree to do so. Patients demand more and more care in order to get what they have already paid for. They'll start going to the clinic more frequently. They'll start having unnecessary procedures, possibly. Insurance companies end up receiving too little funds from patients to pay the rising costs of health care. So again, patients are trying to come out ahead, the insurance companies are trying to get ahead, and physicians are trying to get ahead. So what's the solution here? What are we going to do here? Let's put more rules on this system. Maybe that will solve the problem. So we need to introduce a few more terms. A network is a group of healthcare providers that has agreed to take reduced payments in order to have access to a larger number of patients that are subscribing to an insurance plan. And major medical is a high deductible plan that covers a patient in the event of excessive medical expenses. So in theory, by placing limitations on the loopholes people found to tip the scales in their favor, the entire system is made more fair. But in reality, more rules results in higher administrative costs, and there are always more loopholes to be found. So as a result, you get something called a Health Maintenance Organization, or HMO. This is where the PCP, the primary care physician, is the gatekeeper to more specialized care. If a patient wants to see a specialist, he or she has to go to the PCP first. Obviously, patients don't like this. Insurance companies do like this because a lot of times the PCP can provide care at a much lower cost than the specialist. And with an HMO, in order for medical expenses to be covered, the provider has to be in the HMO network. You have a network of physicians that have agreed to the HMO plan, again, in order to gain access to more patients. And as a patient, either you use the in-network physician or you're going to pay a lot more money to go outside of the network. Then a preferred provider organization, or PPO, is where there's no gatekeeper to see a specialist. As a result, individuals don't have to go to their PCP. They can choose whatever specialist they want. So the patients are happier with this. However, the cost is still higher for out-of-network care. And this plan tended to cost more than the HMO plan because of the higher specialist cost relative to the PCP being able to provide the care. The next question says, what problems came about when HMOs and PPOs were introduced? The HMO and PPO drive down the payments to physicians and hospitals. The physicians receive less compensation per patient, and the quality of visits is decreased in order to generate a higher quantity of patient visits. The patient pays more and more for less and less medical care. In short, the third-party payers drove down the cost of care, but the physicians counter by decreasing the quality of care. In this scenario, the patient loses on quality. Physicians that are unsatisfied with the new arrangement leave the system and establish new systems. Maybe they go back to the old system and stop accepting insurance. There's some freedom to go in and out of the systems, but that's becoming more difficult as these systems become bigger. So if the physician wants to establish a new system, what options are there? Minor emergency clinics are heavily utilized by patients without third-party coverage. They usually offer no primary or secondary prevention at those clinics. There's also cash-only clinics. This is where physicians exit the system and say, you know what, I'm tired of dealing with insurance companies. I'm just going to accept cash only. The physician refuses to take a third-party payment, essentially returning back to the old patient-physician system. The patient may or may not carry major medical coverage in seeing their physicians. A sliding scale clinic is another option. This tends to be more of the nonprofit clinics. So the patient pays a nominal fee based on their income, based on their ability to pay. These clinics are usually run by charities with a volunteer physician in order to minimize costs. And to add another level of complexity, some physicians will develop what are essentially their own insurance plans for their patients. This is called concierge medicine. This is where the physician charges an annual fee. Maybe it's $1,200 a year for a specifically designated set of services, possibly unlimited visits, maybe 4 visits a year, whatever bundle of services a physician decides to provide for that particular fee. Boutique medicine is where the physician offers unique services that aren't covered by insurance but are desired by affluent patients, usually cosmetic in nature, in order to increase clinic revenues. Botulinum toxin injections for wrinkles would be an example of a boutique service. Insurance companies aren't going to pay for Botox, for cosmetic reasons anyway, but it could generate a little bit of additional revenue for the physician. And group physician networks are when physicians say, you know what, we're tired of outsiders taking a piece of the pie, let's just get together with a group of physicians. So in an effort to regain control of their own payments, physician groups can form clinics, build their own hospitals, run their own surgery centers. And what they discover, usually, is that in order to run such a big venture, you need to create a hierarchical structure with its own administrative costs. And so in some ways, they just recreate the business that they just left. But as physicians become more business savvy in this process, business professionals and physicians start communicating better, they start to develop some pretty inventive solutions like the list you see in the study guide. A formulary is a list of medications for which insurance companies will pay. Generics are preferred usually in formularies, but there's also a list of medications that the insurance company will not pay for, but the patient can choose to pay for them on their own if they like. Utilization management is when you have someone whose job it is to evaluate the appropriateness, necessity, and efficiency of healthcare services. So if a patient only needs to stay in a hospital for 3 days, but some physicians might be keeping those particular patients in for 4 days, that's not the best utilization of the healthcare system. So these utilization management professionals try to hold individual physicians accountable for thinking about how much things cost. The resource-based relative value scale is a scale that determines what a physician should be paid for a given procedure or service as determined by the CPT code. This is where the third-party payer says, okay, if a primary care physician in Texas does an EKG and reads it, we'll pay one fee. If a cardiologist in New York does an EKG and reads it, we'll pay that physician a different fee because there are differences in specialization, in location, and in liability costs. So there's some group that tries to determine how much should be paid for each service, for each type of physician, for each region of the country. Again, the goal is to make the system as fair as possible. Evaluation and management codes, or E&M codes, are numeric codes that communicate a level of care provided to the patient so that the physician can be compensated. For example, for a simple outpatient clinic visit, a physician might document the visit as a 99212 code, and for a complex outpatient clinic visit, the physician might document the visit as a 99214 code. ICD-10 are diagnosis codes. CPT stands for current procedural terminology. These also are numeric codes that communicate what specific procedure a physician performed. For example, if you performed a lumbar puncture on a patient, you would document that procedure as a 62270 in order to receive reimbursement for the lumbar puncture. So now there are more complex, bigger entities like managed care organizations or healthcare organizations. You can also group accountable care organizations in here. These are organizations that attempt to maximize the quality of care and minimize the cost of care. They use techniques such as encouraging patients and physicians to choose less costly care, providing recommendations regarding inpatient admissions and lengths of stay, and emphasizing preventive medicine. These things are all accomplished through a designated utilization management person or a utilization management department. In the EHR, the Electronic Health Record System, sometimes referred to as an EMR, is important here for those entities because in theory there are great efficiencies to be gained, specifically in the ease of sharing records with other physicians so that redundant tests are not performed, improving primary and secondary prevention through the use of system reminders to the physicians, and reduction of medical errors in prescribing medications. Now, the reality of the electronic health record system is that most physicians do not like to use it, and it's starting to look like it does not improve the quality of health care delivered. My suspicion is that this is because, with the adoption of the EHR, more of the art of healing and the therapeutic bedside manner is lost. So since it is a loss for the art of healing, it may also be a loss for the business of healthcare. Additionally, physicians complain that they see fewer patients in a day due to the burden of the EHR. And the reality is that some healthcare systems will prefer to use an EHR and some will prefer not to use an EHR. The next question says, what about those without the financial resources for healthcare? Let's talk about Medicare and Medicaid for a second. Medicare and Medicaid is essentially government health insurance for specific groups of patients. So a patient over age 65 qualifies for Medicare. Patients that are disabled or destitute qualify for Medicaid. So maybe you can remember the E at the end of Medicare stands for or represents elderly, and the D at the end of Medicaid stands for or represents disabled or destitute. And then there's also Children's Health Insurance Plan, or CHIP. CHIP is a combination of state and federal funding of children's health care. With CHIP, the state and federal government assists parents in paying for the child's medical care when the parent is having financial difficulty paying for medical care on their own. City, county, and state-funded health networks are more local networks that are developed to care for indigent patients that are paid for by local taxes usually. Federally funded teaching hospitals receive federal funds. So this is why teaching hospitals exist and are able to practice medicine. If the ability to fund the healthcare system federally decreases, it could create a financial burden on teaching hospitals. Federally funded VA hospitals are a network of hospitals for military veterans. And then there's the Affordable Care Act. Since the Affordable Care Act is relatively new and seems to be changing every year, it's not very likely to be on your test, and we're not going to talk about the pros and cons of this particular legislation right now. But let's go into a slightly different direction and talk about how physicians are compensated in all of these systems. This is highly testable. There's fee-for-service, where payment is provided for a specific service. You're going to get paid a certain amount of money for a runny nose visit and a higher amount for seeing a patient with multiple chronic complicated problems such as coronary disease and diabetes and hypertension. One involves much more complex decision making, so you're going to get paid a lot more. Capitation is where the physician receives a fixed payment for a specified period of time or a specified number of patients. This could be ER shifts or minor emergency shifts, or a concierge practice where they're paid by the year. With ER shifts, typically physicians are paid by the hour. HMOs might also have capitation and pay you to provide care for a certain number of patients in a patient pool, regardless of how many patients you actually see. Salary is where the physician is paid a specific amount regardless of the amount of work performed. This is common in university hospitals. If a physician at a university hospital is taking care of patients and teaching, how do you compensate for teaching? How do you determine what is a fair reimbursement for teaching time? Most physician educators are given a base salary, and that covers their fair compensation. Pay for performance is where the physician earns more if he or she meets pre-established targets. So the healthcare organization pays you more if you're meeting certain criteria, like vaccinating a certain percentage of your patients, or making sure they get their colonoscopies, or checking hemoglobin A1C in all of your diabetics. Non-payment for performance is where they don't pay you if your patient has a complication that could have been avoided. So not only is there an incentive to do well, now there's a disincentive to do poorly. Pressure sores acquired during a patient stay would be an example of an avoidable complication. So where are we now? What problems are we facing in the healthcare system currently? Well, there's young invincibles. Young invincibles are people, usually under 30, that tend not to have many health problems and tend not to purchase insurance. So in order for a third-party payer to afford to care for an ailing patient at a low premium, healthy patients must be present to bear the burden of the additional expense. If you were an insurance company with an insurance plan only covering patients over age 80, do you think the cost of providing that plan and paying out for health care would be excessive for those patients over age 80? Absolutely. So you'd have to charge those patients a lot of money. And so a way to get around that particular problem is to say, you know what, I'm going to take care of patients 80 and older, and I'll also bundle in there patients 15 to 25. Those younger patients aren't going to cost as much, so they're sharing the burden of the financial burden of caring for those older patients. One of the selling points of the Affordable Care Act is that everyone shares the burden. Freedom of choice. Patients that need others to carry the burden of their healthcare expenses are at odds with those that want to be free to not have to carry that burden. So the 80-year-olds are saying, come on, young guys, help us out here. And the young patients are saying, I don't want to pay for insurance. I don't even need insurance. So there has to be a meeting in the middle somewhere, and that is what makes the insurance system so complex. Excessive complexity is also a problem. This overly complex system that we've just been discussing leaves patients at a loss to understand where they need to go for healthcare. Plus, you have to hire people just to manage the complex system, which drives the cost of healthcare even higher. And of course, more administrators means higher healthcare costs. Everyone still wants the biggest possible piece of the pie. Patients want the best, most expensive care. Physicians want the highest reimbursements. Insurance providers and drug companies want the largest profits. Physician shortage can be a problem. Many physicians now see better opportunities elsewhere and are leaving full-time medicine. The population continues to increase and the percentage of geriatric patients increases, and there simply aren't enough physicians to go around. And another problem is the concern of insufficient government funds. Specifically, it'll be very difficult for the government to pay for Medicare for the baby boom generation. So what are some of the solutions that are developing? I'm not saying any of these solutions are the correct solutions. I'm just pointing out that these are some of the things that we see taking place. Additional government involvement in the healthcare system so that citizens have access to some level of affordable insurance. Patients taking responsibility for their own health via the internet by way of complementary and alternative medicine, via over-the-counter medications. We're definitely already seeing a lot of this, and this has created a booming industry in the sale of vitamins, herbs, and alternative medicine therapies. Patients seeking U.S.-trained physicians practicing in developing countries where the cost of care is low. Maybe as a patient, you go to the Philippines to have your hip replacement surgery because it costs much less there. This is called vacation medicine. New generic medications that help lower the cost of health care. As many brand name medications become generic, physicians are able to treat patients at a much lower cost. Cooperative healthcare teams that help reduce the need for costly hospitalization. So maybe you need to see a certain patient every single month because of their medical complexity. Well, if a PA can see them on the odd months, and then you can see them every other month, you've just decreased the cost of providing care to that patient. Or maybe a home health person can stop by on a daily basis and then report back to you how things are going. Having these lower paid professionals help out the system can reduce the overall cost of care and help provide higher quality care. So physicians are now being taught how to run these healthcare teams. More mid-level practitioners to meet the rising demand. It takes a long time to train a physician. If you need more healthcare providers in a short period of time, go for the mid-level practitioner, like a nurse practitioner or a PA. It only takes 2 or 3 years to train them versus 5 to 7 years to train a physician. Increased reliance on protocols established by evidence-based medicine rather than physician individualization of care. Reducing the privacy of medical records among medical professionals and insurance companies for increased efficiency in the coordination of care. Electronic health records, or EHR, again also known as electronic medical records, or EMRs. I already discussed earlier in the lecture the nature of those. Quality measures that are followed, such as LDL levels, hemoglobin A1C, and screening colonoscopies that may be a determining factor in physician compensation. All right, let me close this complicated lecture by saying that there will always be a place for physicians in the healthcare system who are occasionally willing to accept handmade crafts or farm animals or something else as payment. Also, keep in mind that it is permissible for patients to provide gifts to physicians in addition to their normal compensation, so long as those gifts are less than $50. All right, go ahead and go through the end of session quiz, and then we'll go through those answers together. First question, what is the difference between a premium, copay, and deductible? A premium is the amount paid to an insurance company, usually as a monthly fee. A copay is the fee that the patient pays out of pocket at the time of service. A deductible is the out-of-pocket expense that needs to be paid before insurance begins to pay. Next question, which usually offers a greater variety of physicians to choose from, HMO or PPO? PPO offers a greater variety of physicians to choose from. Next question, what is the difference between being paid by capitation and fee-for-service? Both are ways that physicians are compensated. Fee-for-service is a payment provided for a specific service, like a clinical visit or a surgical procedure, and capitation is a fixed payment for a set period of time or for a set number of patients, such as a shift at an ER or an emergency clinic, or a global fee for joining a concierge practice. Next, what must a hospital submit to a third-party payer in order to receive payment for services? The hospital must submit an ICD-10 diagnosis code and also CPT codes for what was performed on the patient. What department in a hospital oversees the maximization of the quality of care while minimizing the cost of care? The answer to this question would be the Utilization Management Department, or sometimes simply referred to as Utilization Review. All right, that's the end of the end of session quiz, and that's the end of our healthcare system video.